Premature Ovarian Failure, presented and narrated by Amy Wilson, RN. Premature ovarian failure is defined as a condition that leads to an absence of the menstrual cycle or disorder of the menses for 4 or more months and presents with decreased levels of estrogen and increased gonadotropin in women under 40 years old. The cause of premature ovarian failure is most often idiopathic, but can also result from genetic, autoimmune changes, surgery, or following cancer treatment with chemotherapy and/or radiotherapy. Premature ovarian failure is relatively uncommon and affects 1% of women younger than 40 years of age and 0.1% of women younger than 30 years of age. Although the incidence is low, it is not an uncommon finding in clinics specializing in women's health. To minimize the morbidity associated with estrogen loss, it is important for providers and nurses to understand the health implications and be knowledgeable about appropriate treatment options. The diagnosis of premature ovarian failure should always be considered in any woman presenting with a history of primary or secondary amenorrhea or oligomenorrhea, vasomotor disturbances, or other signs of estrogen deficiency, and these may be confirmed by the detection of an elevated serum level of the follicle-stimulating hormone. Unfortunately, for most women, the cause is unknown. There are, however, some causes that may be identified, which include autoimmune disorder, genetics, the end of a treatment for cancer with radiation or chemotherapy, a hysterectomy with both ovaries removed, thyroid dysfunction, Turner syndrome, viral infection, inadequate gonadotropin secretion or action, or possible eating disorders. Some women may continue to have normal periods and show no symptoms. Diagnosis may only be discovered when the FSH levels are measured and come back elevated. Always evaluate for changes in a patient's menstrual cycle. Some signs and symptoms may include irregular periods, hot flashes, night sweats, a decrease in sexual drive, irritability, painful sex, thinning and drying of the vagina. When diagnosing premature ovarian failure, the common tests that are part of the assessment include pregnancy test. This test checks for the possibility of an unexpected pregnancy in a woman of a childbearing age who has missed a period. Follicle-stimulating hormone test. FSH is a hormone released by the pituitary gland that stimulates the growth of follicles in your ovaries. Women with premature ovarian failure often have abnormally high levels of FSH in the blood. Estradiol test. The blood level of estradiol, a type of estrogen, is usually low in women with premature ovarian failure. Prolactin test. High levels of prolactin, the hormone that stimulates breast milk production, in your blood can lead to problems with ovulation. Karyotype. This is a test that examines all 46 of your chromosomes for abnormalities. Some women with premature ovarian failure may have only one X chromosome instead of 2, or may have other chromosomal defects. FMR1 gene testing. The FMR1 gene is a gene associated with Fragile X syndrome, an inherited disorder that causes intellectual problems. The FMR1 test looks at both of your X chromosomes and makes sure that they appear to be normal. Awareness of long-term health risks and necessary follow-up is needed. Despite the significant impact of POF, discussion and plans of care do not exist in most clinics. Beyond the annual exam, there are no guidelines for routine office visits to monitor blood pressure, lipid levels, bone health, effective hormone therapy on the lining of the endometrium, effectiveness of hormone therapy to control menopause symptoms, health of the vaginal tissue, status of BMI, sexual health, depression, or to discuss the desire to pursue fertility. Overall, the entire healthcare community could better understand the approach to diagnose, treat, and follow up. Successful management of POF requires a holistic approach and collaboration of healthcare workers. Once the diagnosis has been made, managing the patient should include the patient's mental, spiritual, physical, and social well-being. Generally, women who are diagnosed are younger than the age of 40, and it is important to provide resources for support groups and education. Health risks may vary, but all patients are at risk for the following: infertility. Inability to get pregnant may be the most troubling complication of premature ovarian failure, although in rare cases, pregnancy is possible. Osteoporosis. The hormone estrogen helps us maintain strong bones. Women with low levels of estrogen have an increased risk of developing weak, brittle bones. Depression or anxiety. The risk of infertility and other complications arising from low estrogen levels may cause some women to become depressed or anxious. Cardiovascular problems. Individuals with early loss of estrogen have been shown to have an increased risk for cardiovascular mortality. What follows the diagnosis of POF is variable. To begin, if a patient is found to have POF, she may be treated with hormone replacement therapy, which may or may not be cycled, started on birth control, referred for implanted hormone therapy, or compounded hormone therapy, or not provided with hormone therapy in any form. If pregnancy is desired, she may be referred to a reproductive endocrinologist for specialized hormone therapy and consideration for in vitro fertilization. The timing of this option also varies. Some providers feel this should be sooner than later. Others propose allowing the patient to wait. Treatment for premature ovarian failure usually focuses on the problems that arise from estrogen deficiency. The primary treatment option for POF is hormone replacement therapy. This has been shown to decrease menopause symptoms such as hot flashes, night sweats, and vaginal dryness. Estrogen is typically prescribed with another hormone called progesterone. Adding progesterone helps protect the lining of the uterus from precancerous changes caused by taking estrogen alone. The combination of hormones may cause vaginal bleeding again, but won't restore ovarian function. Depending on health issues and personal choice, hormonal therapy may continue until around age 50 or 51, the average age of natural menopause. In older women, long-term estrogen plus progesterone therapy has been linked to an increased risk for heart and blood vessel disease and breast cancer. In young women with premature ovarian failure, however, the benefit of hormone replacement therapy for heart health may outweigh the potential risks. In addition, hormone replacement therapy offers bone protection. Both calcium and vitamin D are important for preventing osteoporosis and may be recommended. It is important to consider suggesting bone density testing before taking supplements to get a baseline bone density measurement. Keep your bones strong. Women who produce low levels of the hormone estrogen are at an increased risk for developing osteoporosis. Work on maintaining strong bones. To do that, eat a calcium-rich diet, do weight-bearing exercises such as walking and strength training for your upper body, and avoid smoking. In terms of the bigger picture, there appears to be limited research examining hormonal and non-hormonal treatment options for women with premature ovarian failure, ovarian deficiencies, and early menopause. This is unfortunate, since premature ovarian failure has psychological, physical, and reproductive consequences, including infertility, hot flashes, vaginal dryness, loss of bone mass, sexual dysfunction, increased BMI, depression, and cardiovascular problems, including ischemic heart disease. The plan of care for patients with premature ovarian failure should be individualized and include regular screening for these health issues. It should also take into consideration the patient's existing risk factors, including their family history. Increased awareness and knowledge of premature ovarian failure will allow the providers and nurse to provide compassionate, high-quality, and evidence-based care.